Congenital critical heart disease, or CCHD. Congenital heart disease is the most common birth defect. AAP estimates that about 20 per 10,000 babies are born with CCHD. Newborns discharged with undiagnosed CCHD may experience serious problems, such as cardiac collapse or death within the first few days or weeks that they are at home. Prenatal ultrasounds detect fewer than half of the cases of CCHD, and predicting saturations based on visual examination of color is unreliable. Prior to discharge, some babies with CCHD will have normal exams and not appear cyanotic. Detectable CCHD defects by pulse oximetry. Critical conditions: coarctation of the aorta, double outlet right ventricle, Epstein anomaly, hypoplastic left heart syndrome, interrupted aortic arch, pulmonary atresia, single ventricle not otherwise specified, tetralogy of Fallot, total anomalous pulmonary venous return, transposition of the great arteries, tricuspid atresia, truncus arteriosus, and other critical CHDs requiring treatment the first year of life. Detectable CCHD defects by pulse oximetry. Non-critical conditions identified using pulse oximetry: hemoglobinopathy, hypothermia, infection including sepsis, lung disease congenital or acquired, non-critical congenital heart defect, persistent pulmonary hypertension, other hypoxic conditions not otherwise specified. CCHD screening results for 2022. Critical congenital heart disease screening. Pulse oximetry testing is conducted by placing a sensor on the newborn's right hand and foot to measure the amount of oxygen in the blood. 93% of newborns were screened for CCHD, and of those, 0.1% of newborns failed their CCHD screening. Timing of CCHD screening: after 24 hours of age, or as close to discharge as possible if less than 24 hours of age. Other circumstances and considerations: newborns that fail initial CCHD screening should repeat pulse oximetry measurements in 1 hour. Please do not repeat if the result is 89% or less in either the right hand or foot. Refer for an assessment. For NICU or SCBU admitted newborns, the screening test should occur prior to discharge or once the newborn is weaned from supplemental oxygen. Prenatal CCHD diagnosis. Pulse oximetry is not indicated for newborns diagnosed with CCHD prenatally. For these newborns, postnatal echocardiography should be performed. CCHD, pulse oximetry screening equipment. For this test, you need a hospital-grade pulse oximeter designed for neonates and 2 disposable pediatric pulse oximeter sensors. They are used on the right hand and either foot. CCHD screening procedure. Perform pulse oximetry screening in a quiet space, away from noises and harsh light. Ensure that the skin is clean and dry before placing the sensor on the infant. Skin color, like acrocyanosis or jaundice, do not affect the pulse oximetry reading. Swaddle the infant to reduce infant movement and crying. The screening should occur in the right hand and either foot. If using only one pulse oximeter, test one site right after the other. Place the probe on the palm or sole of the hand or foot, wrapping the light emitter around the lateral aspect of the hand or foot. The photoemitter and light emitter must be directly opposite of each other to obtain an accurate reading. Secure the probe to the infant's hand or foot using the adhesive or foam tape recommended by the vendor. Do not hold the probe with your hand. Allow the pulse oximeter to remain on the infant's hand or foot for at least 30 seconds before attempting to obtain a reading. Ensure that the pulse wave, or arterial pulse, is consistent, indicating perfusion to the site being monitored is without motion artifact. Measure and record baseline oxygen saturation. Use AAP-endorsed CCHD screening algorithm to determine the outcome. Refer to the algorithm. Pass result or fail result means action is needed. Provide appropriate follow-up as needed once results from pulse oximetry screening are completed. Oxygen saturation cutoff levels. All of the following fail. An oxygen saturation measure of 89% or less in either the right hand or foot. Oxygen saturation is 94% or less in either the right hand or foot on 2 measures, each separated by 1 hour. Or a 4% or more absolute difference exists in oxygen saturation between the right hand and foot on 2 measures, each separated by 1 hour. The following is a pass. Any screening with an oxygen saturation measure that is 95% or greater in the right hand and foot and has a difference of 3% or less between the right hand and foot readings. Failed CCHD screening. Triage. Examine the newborn to ensure hemodynamic stability. Evaluate the newborn for hypoxemia. Depending on the status of the newborn, this may include a septic or a pneumonia evaluation. For symptomatic newborns, prompt rapid evaluation is key. They may need potential urgent transfer to a center with advanced care capabilities. Asymptomatic newborns will often appear normal and have no clinical findings other than the low oxygen saturation. A thorough evaluation is necessary. Consult with a cardiologist or neonatologist. Perform an echocardiogram. Do not discharge the newborn until the underlying reason or hypoxemia has been identified or the hypoxemia has resolved. Documenting CCHD results on the newborn screening card. All pulse oximetry screening results must be reported on the dried blood spot card in the CCHD results section. Do not hold the dried blood spot card if CCHD screening results are not available and the DBS card is ready to be shipped. Please fill out all areas of the DBS card. CCHD results reporting requirements. Dried blood spot card. Write the final CCHD screening results on the DBS card. DBS specimens must be shipped to GPHL within 24 hours of collection. Please do not delay sending the DBS card if CCHD results are unavailable. Delayed screening report form. Complete the delayed screening report form if the CCHD screening was completed after the DBS card was submitted. You can fax or email those results to DPH. Delayed screening report form. This is the method of reporting to be used if CCHD screening was completed after the newborn screening dried blood spot card was submitted. The new form was released in 2023. It no longer captures screening times. Please fax a copy or email a copy of the delayed screening report form to the Georgia Newborn Screening Program.
If you have additional questions or need assistance, please contact the Georgia Newborn Screening Program. The program can be contacted by email at dph-nbs@dph.ga.gov. Our fax number is 404-657-2773. Our webpage is www.dph.ga.gov/NBS, or you may contact the Georgia Public Health Laboratories Newborn Screening Unit. Their phone number is 404-327-7950. Their fax number is 404-327-7919, or their webpage is www.dph.ga.gov/lab. All forms, including specimen outfit order forms for newborn screening supplies, are posted on the Georgia Newborn Screening Program website at www.dph.ga.gov/NBS. Thank you for screening Georgia's newborns.